So really, as we think about hospital reconfiguration, we can get very siloed. So we really do need to bear in mind the sort of the mantra that NICON is beginning to use a lot more is hospital to treatment to prevention, hospital to community, or treatment to prevention, hospital to community, and analog to digital. So we're really thinking about those things as we think about our hospital reconfiguration. So we're really, really delighted to have you here today, and I'm going to hand directly over to Mark.
Thanks very much, Heather, and thank you, everybody. And this is the second webinar, and many of you joined us for the first webinar when we looked at the 3-year plan with Jim Wilkinson. Absolutely amazing numbers. If everyone turns up, we're looking at maybe 160 people from right across health and social care, those with lived experience, charities, commercial, trusts, directors, chairs, the whole platform. And that's one of the joys of NICON. We all come together for this. Really grateful to Peter Jakobsen for taking out some time. Peter's the Director of Health Service Transformation in the department. Small portfolio, you might say. Not, but Peter is an amazing guy, and he's been in the Department of Health really from 2019 in his current role as Director of Health Service Transformation. The reconfiguration framework for Northern Ireland was obviously launched by Minister Nesbitt on the 1st of October 2024. And really what I want to do now is let Peter say a few reflections on that. And then we're going to go to some reflections from members of the audience and questions. And this is a conversation. It is not a didactic lecture, but because of the numbers, rather than trying to go between 6 or 7 screens to look and see who's put their hand up, if you could put your question into the chat function, and behind every successful man is a platform of very successful ladies. We have Robin, Vicky, and Megan and Heather looking at all those questions coming through. So we want to make the next 1 hour or so really, really interactive. This is one of the critical pillars of Mark, the journey that we're on at the present time. We just lost your sound. Oh, can you hear me again?
I can hear you okay, Mark.
Can you hear me okay? Yep.
I can, yeah.
Yeah. Oh, Heather's maybe lost me. Okay, all good. So without further ado, we're going to hand over to Peter Jakobsen. As he's presenting, think about your questions for the chat. Think about any comments you want to make, and let's have a really good, constructive, helpful discussion on the reconfiguration framework. Peter, thank you.
Thank you very much, Mark. So I think Robin's going to share my slides. There's about, I think, 12, 13 slides, which I'll run through. It should take about 10 minutes or so just to set the scene. And it's really about...
It's Megan doing that for you, just so you know who to call
Megan,
on.
sorry.
Yeah, sorry, I'm doing something else, but she'll take over
no,
that.
No problem. Thanks, Megan. Yeah, so look, thanks for the opportunity to present today. As we're in the middle of a public consultation, so it's really timely to have this discussion today as well. It's supposed to feed into all that and hopefully encourage some of you to actually contribute to the actual consultation on our website. Next slide, please, Megan. So I suppose today's the purpose of today really is to have a discussion about the consultation document. What I'll do in the presentation is to outline the concepts, actions, and some of the consultation questions in the consultation document, and then is to inform the discussion today. Next slide, please, Megan. I'll start by saying a little bit of strategic context, and Heather already alluded to some of this, that when we think about, or certainly when the public think about health and social care, often they think about hospitals, but actually the system is so much bigger than that. And the population actually gets most of their needs met through our community pharmacies, general practice services, and social care, and so on, and other community services. So within this system, hospital care is provided only when it's really needed. And the slide here really shows, I suppose, that one of the key policy areas that we are taking forward is elective care, and we are doing that through various elective care centres. And often the amount of centers depend on the level of demand, but also how specialist the skills are. And that's why, for example, we only have a single regional trauma center, simply because the skills are so specialist, you can only really maintain that on a single site. And therefore, we need to bring patients to that center when they need that kind of service. We can also look at this from the perspective of urgent and emergency care, and that's on the next slide, please, Megan. So this really, I suppose, says the same thing, that actually most of the care is provided in the community, close to home. And indeed, self-care is a really important element of this. I think we shouldn't overlook. And only when needed should people attend hospital, indeed, our emergency departments. But this particular consultation is, however, focused entirely on the hospital network and how it best can be configured to meet the demands for hospital care and provide the complex and highly specialized services there for those who really need them. And next slide, I'll talk a bit about the consultation document itself. So we posed a number of questions. First, really, why do we need to change? Well, we all know there's been dramatic changes in healthcare, improved therapies, better technology, and increasingly skilled workforce. And that's had really positive impacts in terms of better outcomes and longer lives for our population. But in parallel, we also seen a very significant growth in demand and pressures on our services, both hospital and out of hospital. And there's therefore a clear need to maximize capacity and sustain high quality and efficient services. And this actually also drives the need for these elective centers of excellence. In terms of the what, it's about creating safe, better healthcare services. Some of the things we used to see are equal access, particularly for waiting lists, and also more resilient and sustainable services. In terms of the where, we need to make best use of the entire hospital estate and continue to adapt to changing population health needs. In terms of the how, well, the document puts forward a number of actions on how the network can operate more effectively, and I'll return a little bit to those later on. But also in terms of when, well, reconfiguration is an ongoing journey, and actually we have actually done quite a bit already. But future reconfigurations can be either trust-led or indeed departmental-led. Next slide, please, Megan. I'll say a bit more about some of the key concepts. So all hospitals have a critical role to play in creating and sustaining the Northern Ireland hospital network, and all hospitals will have a number of core services with clear patient pathways across the network. We need local service provision where that is possible, and then central where that's necessary. The Minister has been very, very clear that it's not about closing hospitals or cutting funding. It's about making best use of the resources that we do have. To be effective, the network needs to be built on collaboration and support within and also across trusts. And NIAS obviously play a really critical, important role in all of that. Really important, future reconfiguration should be driven by planned changes rather than unplanned service collapse. And that is, I think, an absolute key point. It's paramount there's always local involvement and engagement in the decision-making. So I think it's also important to say what the consultation document does not do or does not include, and I'll cover that on the next slide, please, Megan. So as I said, important to say what the document does not do. It doesn't provide any new legal powers to the trust or anyone else. It doesn't put forward any new reconfiguration proposals, and it doesn't therefore change or downgrade any other hospitals. It doesn't revisit previous reconfiguration decisions, but is forward-looking about what future reconfiguration should deliver. As I said earlier, this is about seeking views on the creation of a hospital network that has quality and safety as essential criteria. The document itself also describes the hospital network, and the next slide will expand a bit on that. Next slide, please, Megan. So within the development of the document, there was 4 different hospital types we identified. First of all, local hospitals, which is a diverse group that delivers a range of services to meet local population health needs. And they support the general and area hospitals, probably too many to list right now, but they're all listed in the document itself. The general hospital category, which is hospitals deliver a range of defined secondary care services, including unscheduled care, to meet the needs of wider, more isolated geographic location. They also play a crucial role as regional elective centers. and this includes Daisy Hill, Southwest Acute, and Causeway. And then we have the area hospitals that delivers the full range of secondary care services covering both scheduled and unscheduled care. And that includes Antrim, Ulster, Craigavon, and Gelton hospitals. And then also the Belfast hospitals, which provide both the area function and the specialist regional services in Belfast. And that takes me then on to the regional centres. And this final category is really not defined as a single hospital, but more as a specialist services that can only be provided usually in a single location in Northern Ireland. And I mentioned major trauma as an example of this. Next slide, please, Megan. So I mentioned earlier, we have a number of actions that are really designed or intended to try and encourage better collaboration, better networking amongst the hospitals. And that is really central to this. And one of the, I suppose, key areas are a workforce, funding, engagement, local communities, cross-task working, and digital solutions. So I think we can probably group these actions into 4 themes. The first theme is around patient travel. There's a second theme then about how our resources, mainly workforce and services, are allocated across the hospital network. The next slide then sets out the rest of the actions. So next slide, please, Megan. So the third theme, as you can see there, is around workforce issues, such as the allocation of medical trainees and workforce planning. And then the fourth and final theme is around mechanisms to promote greater collaboration across our hospitals. And to finish up, I'll maybe highlight some of the questions that we posed in the consultation. Next slide, please, Megan. So we listed the consultation questions there, and you can see they kind of logically follow from the sort of key concepts and issues that I just talked about. In addition to these questions on these 2 slides, we also seek views on equality and real needs issues in our consultation online. Next slide, please, Megan. So that's just the final 3 sort of main questions we posed. I'll maybe go on to next steps. Yeah, thank you, Megan. So in terms of next steps, well, the consultation runs till the end of February. We are then obviously going to consider that feedback we get and then draft a consultation response and share that with our minister for discussion. Subject then to the feedback and the minister's views, we'll tend to then implement the proposed actions, and we'll set up a structure around that. And I recognize that many of the actions probably will need to be refined before we get to that stage, but that's part of the, I suppose, response to the consultation. So Mark, Heather, that's probably all for me in terms of just setting the scene. I'm happy to participate in the discussion.
Thank you very much, Peter. And I know from looking at the list, we have a wide range of stakeholders today, and I'm really grateful for everyone coming on. As you have quite rightly said, this is still open for public consultation, and I know you and your departmental colleagues have been going around the country engaging in many public consultations. And I think this is a real opportunity to have a frank discussion. I think sometimes even though we're a small population, there is sometimes misinformation and fear among the community, and it'll be interesting to hear from some of our patient client council colleagues just around how we can, as a system, ensure that the correct information is there, factual information is there about the whole purpose of collaboration and network. Peter, what I'm going to do is maybe go first to get a couple of reflections from some of our audience, just as everyone's planning their questions. And please do feel free to put in some questions in the chat function. Similarly, if you're very keen to vocalize a question, we can make that happen. But as you can appreciate, we have a number on the screens today. So I'm maybe going to start off with someone who has been aware of our system for many, many years, and that's one of our chairmen. I like to call him the father of the house. For those in Parliament, you'll know what that means. So I'm going to maybe bring Tom Frawley in. Tom has seen many reviews of the health service in Northern Ireland, and I just want to get his reflections on this reconfiguration framework. Tom. Microphone, Tom, sorry. That's you, Tom.
All right, that's it. Sorry about that. No, thank you very much. You avoided using probably the more accurate description, which is Tom is a tired old man and has been on this road for a long time. And this is probably, or this type of process is the most challenging and difficult I have found it in my working experience. And I have observed it in all its iterations, certainly since 1973. When there's been a number of these very major processes, and probably none of them have achieved what one would have hoped and get us to a settled position. So it's very difficult, I think. That's the first thing, and we shouldn't underestimate it. I think in that presentation by Peter, what always has struck me about this approach is that it's a very open approach, which in some ways I think is helpful. But I think often the public feel, well, there's nothing definitive in this, it's all words. It doesn't really give us a sense of what happens in Enniskillen or what happens in Coleraine or what happens in Newry, and they're avoiding that. So I think there is a lot of public, as I think has already been alluded to by Peter, misgiving about what's intended here. However, I think it is a very positive and open-ended way to look at the challenge that we have to maximize the system that we have. And there are some really, I think, important opportunities in it that we shouldn't miss. And sometimes the description of our hospitals gets in the way when we talk about area hospitals or we talk about local hospitals. And I think the public in its locality is very protective of the services both it has and indeed in many instances that it would aspire to have, and can see very limited reason why it shouldn't have it. But I think the analysis that we're looking at now really needs us, as it was initiated in Ben Goa in the first place, is to maximize what is both affordable and sustainable going forward, but recognizing, I think, in that last slide that the change will never stop, that there will always be refinement needed. So I think part of the challenge is to get the public to engage, and of course until such time I would suggest as the minister has the opportunity to take the feedback from this particular phase and begin to, in a sense, fill that out into the new system that he would envisage, describing in some greater detail the content of each of these levels of service provision. It's then the public becomes engaged, I'm afraid, because I'm not sure, when Peter would be better placed, but I'm not sure what level of public energy engagement we are currently witnessing in the current process. And it's always hard to judge until we're at the end of the process. But I think that part of the difficulty is mobilizing that public opinion in a way that gives you the sort of constructive dialogue that's essential to build whatever level of consensus can be built in these circumstances. Because I think it's also important to recognize that there will not be unanimity, that people will not necessarily nod their heads and say, yes, this was a very worthy and a very satisfactory experience for us. We're not getting what we'd hoped for, but we believe we were heard. I think that's a very optimistic view. I think people will want to challenge until the very last moment some of the decisions that will be part and parcel of the ultimate outcome, and we should recognize that.
Tom, thank you very much. Peter, any comments just before I move to another focus? Tom has come up with a number of comments there.
Yeah, no, well, I would agree that it is difficult to engage the public in what is a fairly abstract document. There's no specifics in it. I agree with that. And actually, all of the consultation events we've had to date, the discussion has been specific about changes that either has happened or might happen. as opposed to the principles and the concept in this document. So I agree that is difficult, and I think it's going to be a challenge for us actually when we get the feedback. I suspect a lot of feedback will be about specific that has either happened or the public fear might happen, as opposed to the principles and actions that are in here about working as a network. But we'll have to work through that and try and explain that when we set out the response, obviously.
Thank you, Peter. And just on that, maybe comments, questions. You know, we have 1.9 million of a population, and one of the comments here is the abstract rather than the specific. Has that been a protective mechanism because of the fear of rebuttal, the fear of agitation, the fear of taking to the streets if people don't get what they want? Not necessarily what is the best thing for the public in terms of the delivery. And I think your slide showing that the least important part of the delivery of health and social care in Northern Ireland is these buildings called hospitals. There is so much more going on around the periphery of the buildings called hospitals. And with that in mind, I am going to slightly I'm going to go to one of our charities, because again, I think we get a real honest broker in our charities, and I'm going to bring in Sarah Graham. So Sarah Graham from Versus Arthritis. Clearly there isn't a day that goes by that Sarah and her team are not tortured about our waiting lists and the waiting lists in Northern Ireland. And again, within this framework document, you highlighted elective and the separation of emergency and elective to try and look at ways of really dealing with our backlogs and our waiting lists, etc. Sarah, any comments just at this stage?
Yeah, thanks, Mark. Yeah, we've had a look at the consultation and certainly started our draft response. I think some of the things that stood out to us, we certainly appreciated that the voluntary and community sector are recognised as a key enabler within the document. And we certainly see ourselves in that space. And it's how does that bear out in practice? And Heather's even just put a wee note about, you know, are we doing enough to engage in partners in creative solutions? There's been a lot of work within the integrated care system about how to work more strategically with the voluntary and community sector. I think that's the space that we are in and that we want to be in. We are supporting people every day to, I suppose, look after their health, to maintain their condition, especially a long-term condition like arthritis. And we've had a conversation in the round with the Long-Term Conditions Alliance as well, which I chair. And I think just recognising the unique space that voluntary and community sectors and organisations play in the health system, helping people to stay well, helping people to look after themselves so that they don't have to access statutory services until they actually need them. And when you're looking at patient flow and patient beds, that's really, really important. And so how are we being factored into those considerations? The principles that are being talked about, how are we factored into decision making? How are we included in those pathways and recognised as, I hope, an established part of those pathways, or how do we become an established part of those pathways? So we are very much seeing in that prevention space. I was at the department is looking at a rehabilitation framework at the minute, which is excellent. And I remember one of the stats that was given to us was that 70% of hospital beds were taken up with people with long-term conditions. That's huge. And the voluntary and community sector are very squarely in that space in terms of providing ongoing care and support for those individuals before they go into hospital and when they leave hospital. But how are we being involved in the decisions around that patient flow and actually, I suppose, yeah, the big questions that are being asked in this document, which is very explicit about this is we're only looking at statutory services here, and we understand that, and I understand that you need to draw boundaries for consultation, but it's very hard as we, as our own charity versus arthritis, have looked to respond to the consultation, and then as a long-term conditions alliance. For us, it can't be separated. We are all part of the one health system, and to make good informed decisions within statutory health services and hospital care and acute, we need to be part of that jigsaw to kind of get that patient flow picture right. And yeah, so we are more than just a key enabler. We are an instrumental part of the jigsaw. So I suppose that's reflection. I don't know if how others want to kind of riff off of that.
Yeah, and you are absolutely instrumental, Sarah. And I'm just looking at our comments here, Peter, and just as well as reflecting on Peter or on Sarah's comments, Peter. I think one of the important things, and really NICON is a great platform for this. I'm seeing some commentary from Michael really about mental health being excluded per se from the review. Mental health services are key within inpatient services, and not to forget mental health. Let's not treat it as an afterthought. And Sarah Meakin makes some really good points about the role of AHPs, and again, sometimes in the same way as we're often talking about hospitals and not primary care and community care, social care, we're always talking about the doctors and the nurses, and that's not our entire workforce, as we know only too well. Some of the reflections so far, Peter?
Yeah, no, look, Sarah, thanks for those comments. No, I agree entirely. And if I had all the answers to your questions, I'll be doing well. I think that's something we are grappling with. How do we best involve voluntary and community sector? And I think you're right. Increasingly it has to be about out of hospital services to prevent people going to hospital in the first place. And I think the voluntary and community sector play an absolute key role in that. So I think there is more we need to do, and I am hopeful that ICS will help us move more in that direction. I think that's the intent of it. So I would like to see that should hopefully help to involve those other partners greater in decision making. So mental health, yes, it has been excluded from this document, but also after discussion with our mental health colleagues, but they are separately working on a regional approach to mental health and have a very specific strategy around that, which is why we discussed it. And this document started actually, Sarah, a little bit as let's look at everything, but we realized if you look at everything, you end up doing a consultation that's become completely meaningless. It's already quite abstract, so we kind of had to narrow it down and thinking about, well, let's look at a hospital specifically just in this and look at how can they best work together to maximize benefits for all the populations. So that's why it's a narrow focus. It's still quite wide in my mind. So I suppose you can't do everything in one document. I agree with the AHP comments, absolutely. And when we think about workforce, it's about the multidisciplinary team and what each part of the workforce can do. And that's about skills mix and so on going forward as well, how we best use all those skills. So that's absolutely on the radar in all the work we do.
And Peter, Prof Stuart Elburn has made a very important comment there, and I think it's coming up time and again in the chat, and this is how will we get that patient community reformed, integrated health system, and also what are the accountability mechanisms to assure a safe and effective delivery of care to people? And I suppose a side way of that is, if you look at Sweden, a lot of the care is local. The local councils run the care, and the system is not as integral to the delivery of care. So I know we're sort of blending into the integrated care pathway and the work that's been going on in the department there, along with the framework. But any comments just about that?
Well, I think that's, we have obviously existing accountability mechanisms, and as long as we have the structures we have, I think that's what we are working through with the 5 trusts and boards and all the rest of it. And how that links in with ICS, I think, is still work in progress. But those things are clearly important.
Okay, and again, if we come down. I can see Eddie Ritson.
Eddie Ritson, yeah, Eddie would be interested in.
Yeah, I was going to say, Eddie has said really important that we learn as a system, how can we best use our new suite of digital technologies as an enabler? The digital community are part of the approach. I couldn't agree more, Eddie. And in fact, you know, quite often we're very negative in Northern Ireland. Quite often we play ourselves down, but actually, by the middle of this year, we will have one single electronic healthcare record for our population. That is a first. We will be doing that for the entire population. No matter what people think of Encompass at its early stage of influence, we will have a single track record and bigger liaison with our primary care. And Roger's back on, and I'm going to pick on him. I'm sure at some stage, Roger, you're on standby. But there is so much there within technology and within all of our industry support to help us as well. And I think we are entering into a very exciting time where, you know, at its simplest, the person giving their history 16 times in the process of the flow of their journey, from the doctor being called to the ambulance driver to the ED department to the clinicians of all grades to the subsequent treatment. So I think that makes a very good point. Any comments on that, Peter?
No, I agree entirely, and I think we have a huge opportunity here, and bringing it back into this consultation, I think that also presents opportunities for better networking and collaboration across trust, actually. So I think it is a very important enabler for this kind of networked approach that we talked about in the consultation document.
Okay, and again, a commentary here around the Southwest Acute Hospital from Tom White. Some of the events I've attended, there was a lot of talk about beds and flow, pretty much irrelevant for SWA. The big issue is staff capacity, how are elective care centres, which I believe opened, performing, what needs to be done, and when they were open, no figures could be given. But Peter, I'll answer that question. The elective care centres in Northern Ireland are there to ensure that we get maximum productivity. And what we have learned from the lessons of the past is that when you have unscheduled care in a building, that trumps everything, as each and every person on this call would expect. When you're the sickest, that you are sent to the right place to have the most qualified people operating on you to get the best outcome. But when you're trying to do it all things in all places, elective always takes the hit, and the separation of the two has and is continuing to develop increased elective capabilities. And actually, I should say, and I may bring Monica Monaghan in one sec if she doesn't mind to reflect. One of the jewels in our crown is the Southwest Acute Hospital, and the number of specialties that are now operating there is increasing, and we are not finished. We are not finished. The Southwest Acute Hospital, Causeway, Daisy Hill, the Mater Hospital in Belfast, promise you all, will be the most secure going forward because of their identity as an acute hospital dealing with acute medical emergencies with an ED department, but also the joy of a regional service, Monica, do you want to come in there?
Thank you, Mark. Can you hear me?
I hear it loud and clear.
Thank you. I very much welcome this platform for a mature and transparent debate around the consultation. I also welcome the assurances of no downgrade, and I think that's important. I think it's important for those of us who are advocates for our rural communities to bring to the region what we have to offer, and that we are very much part of the solution. We're not the problem. And I suppose it's really the fundamental role, Mark, of the local hospital, and the role of the generalist, those of us that have a a real breadth as well as depth in our own specialties, in medicine, in cardiology, in the management of multimorbidity, chronic disease going forward. So, as you correctly said, we have to have our eye on the emergency department, on the vital role that continues in the Southwest Acute Hospital, the life-saving stabilisation in critical care for our population, but also to have the vision of what can we do in the future for our population that are living with chronic illness and living well with chronic illness, trying to keep them away from the front door. And I suppose we are passionate about integrated care and community and what we can offer as specialists in the role of a local hospital. You talked about workforce, recruitment and retention. And one example was the vision, for example, of putting a cardiac MRI scanner in the Southwest Acute Hospital as one of the 3 scanners in the whole of Northern Ireland. And that has attracted excellent cardiologists. And I have never had a patient complain about having to travel to get this highly specialised test. So that sort of vision helps the local hospital to retain, to recruit, and people are willing to travel outside of the larger regional centres for these tests.
And I think, Monica, you're right. And I want to make an apology to everyone too about sometimes the confusion. So you're absolutely right about the generalist and the role of a generalist. And the difficulty is that in my specialty, that is general surgery, there is no such a general surgeon anymore, unfortunately. And actually, I would prefer we don't talk about general surgery because it gets confused with trauma, emergency departments, it gets confused with acute illness. An abdominal surgeon, a surgeon who simply does an operation in the abdomen. Unfortunately, we have seen throughout the United Kingdom and beyond this degree of subspecialization, which is why we have had to do something different in terms of the delivery of emergency general abdominal surgery. And it's all about the person getting the safest approach. But yet we have led to such confusion out there where we hear about emergency trauma, we hear about all sorts of things, and I think we have failed in that regard to try and bring it around. But just for those that are listening, I think, Monica, you and I are all saying the same thing. No matter where you live in Northern Ireland, we want you to get the best care that is possible. And whilst that may mean travel, that is still get the best care possible. But the reconfiguration agenda, and I'll bring Peter back in before rushing Coulter, the reconfiguration agenda is to get the best out of each of those centres. And for me, we are trying to put more, certainly in my world, into the Southwest Acute Hospital, Daisy Hill and Causeway than we're taking out of it, for the very reasons that you have said. Modern state-of-the-art cardiac MRI, where we're all coming to from the rest of Northern Ireland. And, you know, there may be more news in the future of other services coming in. Peter.
No, thanks. And thanks, Monica, for that. I think that's a really helpful example of how a piece of kit can help attract staff to a hospital. And I think there's an action in the document itself about really considering carefully how we allocate resource. And it's mainly staffing, but actually the example here is it's also scanners and so on across our network to make best use of the capacity we have. And it's about, you know, if there is a bit of space or capacity in a certain site, well, that's where you need to put it. And also, if that can help to attract staff to some of the smaller hospitals, all the better, I think. And that's part of the sustainability and making best use of what we got. So I think that, yeah, thank you for that. That's an important point.
And one of the issues that Monica also raised was about chronicity and about chronic health. And, we know we have an aged population. Our population are getting older with more comorbidities, more chronicity. How are we keeping people out of hospital? Hospital should be the last chance saloon in many ways. Roisin, I was going to bring you in on the discussion. Thank you, everyone. Comments are coming through. Heather, Mon, and Megan will keep me right if I'm missing comments that are important to the contribution. Roisin.
Yes, hi everybody. Good to see so many people on this webinar. And just to say, I was on one a couple of weeks ago with NICON as well, and I really do think that this is a real good way of having that open and transparent and honest debate, and involving as many staff as possible who are working in the service to be part of these conversations. Because many, as you know, many of us have been involved in public consultation events where very few people actually come along. So, for me, I think this is really, really positive. Just a couple of things I wanted to share, probably from our own journey here in the Southeastern Trust, and also as part of the group of the chief executives, we have been very keen working with Peter and his colleagues in the department to have what I call, and Peter will smile, is a master plan. Because whenever we have been leading service change, it tends to be a little part of the system. So, what's happening, for example, in my area in the Down Hospital, or what's happening in Causeway. And that tends to instill a lack of confidence in the public, because the public then tend to think, well, if you're changing this, what else are you going to change? And you're going to close something. And it sets us off on a very negative footing to really have that confidence with our public and our citizens. So for me, I'd always said, we need to set out the overall hospital network to say, look, where are you going to have your big regional tertiary services? Where are you going to have your acute services and your district general services and your local hospital services? And some of the key messages would be, the more we can be in one page as leaders in health and social care about setting out one narrative in the same way that people understand it, so that we call our hospitals, the same things if they do the same functions. And the other point, I suppose, is two things, I suppose, that I've learned along the way is it does take a brave person to be open and honest with the public. And I've heard some of our colleagues on in relation to particularly rural areas, Fermanagh, etc. It's not easy, it's tough, but it is so important, I think, to be open and honest. And probably over some years, it actually wasn't possible to be open and honest with the public. An example I can share with you would be when I came into this post 3.5 years ago. I thought it was extremely important to put on record that there will not be a 24/7 emergency department in the Down Hospital. That will not be happening. But we can't fudge. We need to be open. We need to be straight. We need to be honest. What's possible? What's not possible? And the other thing, I suppose, is to recognise that in terms of our hospital network, we can't just see it in the silo of the health service and hospital network, because Northern Ireland does have specific deficiencies in its infrastructure. So, for example, transport is a key factor in terms of people being able to access services. It just is, and it's not the way it needs to be. So some of these targets and timescales about minutes away from acute hospitals, that has to be factored into the Northern Ireland context of infrastructure. And the second one, I think, is very important as well. We've been talking recently about, yes, we have our hospital network where all our staff hopefully feel equal, and I'm not saying we get it right all the time, but they should feel equally valued, that they're part of a hospital network. So in my organisation, you'd be asked to work in any of the hospitals, and that's really, really important. It's not about a hierarchy of hospitals. Every one of those hospitals are critical to us providing acute services, and they have a distinctly different role, but they all make an equal contribution, and that is really, really important. I think that networked approach works well, and it can be done across trusts as well, as we've seen in some of the regional services. But my final point was in relation to, yes, this is about the hospital network, and the more specific we can be, the more honest we can be, then people will understand this is it. This is how we're going to provide our services. Those providing clinical services are always best placed to develop them. That is, this cannot be driven through politics. It needs to be driven through professional clinical advice and what's best practice in terms of patient safety. But again, my final point there was about, yes, the hospitals, yes, but we need to also recognise about our community infrastructure and our community services. And we have all said, particularly over the last few months, but during pandemic and during other pressures, is that the ability to deliver the shift left in Northern Ireland, we have seen a significant lack of investment in community services, and we now need to really address that or redress that and try and pivot alongside. So I think it's just important, again, not just to say, yes, this is about the consultation about the hospitals, but the hospital network needs to be supported by the adequate community infrastructure and models of care, particularly for older people, where we want to avoid them having to come to acute hospitals. So some of those other parts, I think, it should be factored in to the response to the consultation, that there are a number of principles and a number of enablers that are really critical, particularly to support in local hospitals, such as hospital at home, multidisciplinary teams, rapid response, falls response, and all of those things. We can't just look at this. It's, it's so much. It's not about the buildings. And let's keep on working together in this space and work with the master plan, as I call it. So thank you, everybody. See Peter laughing there.
Thank you very much, Roisin. Comments, Peter, and then I'm going to bring Eddie Ritson in. And again, please keep your conversations and comments coming in. And I'll come back to Tom's discussion there about capacity and elective waiting lists, etc. I think there's no secret that the modernisation of our elective strategy is not to deal with the backlog. It's to deal with the now, the future, the going forward. Okay, and I'll go to Peter again.
Yeah, no, thanks, Roisin, for that. And we work very closely, obviously, with all the trust and the trustee executives in developing this. So welcome the comments. I agree entirely. We have to be honest about what's sustainable, and that's back to, suppose, one of the points made in my slides and in the document. It's really important going forward. We have planned changes as opposed to unplanned service collapse. It's the only way we can properly plan for these changes and actually make sure that we, for example, that the ambulance service have the capacity to deliver the new pathways and so on. So it's really important that this is all planned. I agree entirely on the transport and roads infrastructure. It's probably not what it should be, but it is what it is. And we have to work with the infrastructure that we do have. We are working with the Department of Infrastructure and the Department of Rural Development as well in a cross-departmental way to try and address some of these issues. But as everybody knows, in investment in roads, etc., it's very, very long term. So that isn't going to solve any other issues in the short term, that's for sure.
Peter, thank you very much. Can I just make a little plea to people when they're putting comments into the commentary? Can we manage to have a degree of civility, please? We're having a really open discussion here. We don't need any attacking of individuals in this call. Unfortunately, this is one of the reasons that we really struggle in this country to bring about the necessary safety changes, because some people want to be heard louder than others. So please, a degree of respect for our speakers, or we will eject you from this call. Thank you. Thank you very much, Peter. Eddie Ritson, I'm going to bring you in.
I'm here.
Go ahead, Eddie. On you go.
I kind of put a good deal of my comments already into the chat there, Mark. Thank you very much. It's very hard to disagree with almost everything which has been said. But maybe just to pick up a little bit on Roisin Coulter's comments, I think there's something here with regards to leadership about how we behave. And maybe that comes on your point just a moment or two ago. The need for us to be consistent and deliberate and inclusive and transparent and truthful and honest. And I say we, I do actually mean the big system here. The more that we can speak as a system to each other and to stakeholders and to the public in ways which have those sorts of values at their core, I think the greater the chance of success. And we all need to listen carefully to what Tom Frawley said at the outset here. People have been up and down the hill many a time, and there's a danger that we fall into a habit of learned helplessness, I think would be the phrase, that we kind of we begin to learn that we can't do it because we've been up and down the hill that many times. But the tragedy of getting to that point is that we collectively fail. And, we just, in my opinion, we can't allow that to happen. So that's paying attention to our behaviors, I think, and how we talk about things and how we deal with things is as important as the content.
Yeah. And could you, I think those are fantastic conversations, because I think we're in a new culture where we're trying to talk about system thinking, where all of these bits go together, and we really need to be more respectful of each other. It's not this hierarchy anymore. We just need to be much more creative. You and I have had this conversation quite a lot, because I think the problem that we have is we're trying to fix the problem that we've got now. But by the time we get to there, we need to be fixing a different problem, which is a different pressure on our system. So we really need to be very ambitious in our thoughts. And you know that I think that Northern Ireland, bearing in mind where we are with our digital journey, we could really lean into that and see, could Northern Ireland be an exemplar? Could you say a wee bit more about what would the vision of that look like? Because I know that we've got an electronic care record, but what, is there more that we could do to really have a vision? And that's what I think we need, is if people won't let go of the old until, as Roisin talks the master plan, until you know what good is going to look like, you're not going to let go of the old. So how do we really understand better, talk up more, see what others are doing, or see what we could do better? Because we've also got health and social care. Do you say a wee bit about that?
Well, I think it's easy enough to articulate a vision at a high level. But it's the difficulty we face on the digital journey, as well as the other strategies, is the implementation. It's the how we go about it. And that, Roisin's right that there's learning to be made from other systems. But, digital isn't going to come running over the horizon on a white horse and save a day. We are a people-based service. Yeah. And when we talk about change using digital technologies, fundamentally, we're talking about changing what people do, or changing what people do in a pathway of care, which may mean that somebody upstream or downstream does something differently from what they do today. The change required cuts across teams, it cuts across disciplines, it cuts across organizations. So we need to learn how to do this. This is not, we can go and see what someone else is doing. But when it comes to applying that in Northern Ireland, it's not a shift and replace. We need to learn as a system how we go about changing care pathways. And in my assessment, the only way to do that is maybe on a geographical by geographical basis, taking whole services, take your pick, mental health, cancer, frailty, wherever you want to go, and do proper whole system change. I see far too much still of fragmented activities, initiatives taking place, which are all kind of in the same bucket, but they're not really being properly joined up and managed and coordinated. And I think there's an awful lot more to do in that area to allow us to manage effectively.
Thanks very much, Eddie. I'm going to bring Diane Little in to give an opinion. Camille, I'm going to hold you for one wee sec because I want to bring in a little bit about our workforce and our training, because that's all linked to the framework as well. Diane.
Thank you very much, Mark. I'm from the community in Fermanagh. I'm a student in Queen's University in inequality, doing my master's in inequality and sociology. I'm very concerned about us missing the principle of equity. Both the World Health Organizations and the UN advocate that adhering to the principle of equity will help in advocating, in allocating available resources in a way that will contribute to the reduction of avoidable health inequalities. What I want to know is, how will this process, of reconfiguration, how can we do it fairly so we don't discriminate against people living in rural communities? And, how can this principle of equity, be taken in? Because at the moment, peer-reviewed medical evidence, which does obviously take into account the time, distance, and travel, you know, impact and outcomes in terms of emergency surgery. It shows that over 83,000 people will now be at higher risk of mortality and morbidity, a higher rate of reoperations and complications and longer hospital stays. That's peer-reviewed evidence that I can drop into the chat. So people living in the FODC, this is the highest area of relative poverty. And Peter, you might remember me coming to a recent meeting and giving you a little map showing that. You know, it's the highest rate of relative poverty in Northern Ireland, but these people have, you know, from top to toe of their body, if you think of it like that, are the ones who are paying all of the costs for traveling all of these journeys. There's so little left in Fermanagh. And they're on the most dangerous roads. They're having the most highest risk of accidents and needs. But how is equity a principle that's built into this process? And that's one question. Second little question is, who is actually going to take responsibility? Because we honestly can't figure this out. You know, Pathfinder came and it was said in Pathfinder that we couldn't have any more locums. We weren't sustainable if we needed locums, although everybody needs locums. And for that, we were judged unsustainable. And we had the fantastic Recruit and Retain conference come to this area. It was a big EU-funded conference and it had solutions. And we have solutions, but we cannot see a way to slot those into that process and get heard, you know, about, you know, recognizing the need to create equity through processes of, you know, ensuring, you know, that there's an appropriate package of remuneration and structures and, you know, things put in place to ensure equity. And we need to look at what Declan Bradley found. These things led to the RQIA, you know, and the patient safety, you know, and issues of high risk and suffering and trauma that RQIA have just reported on. So how do we get equity? And how do we get accountability? Thank you so much.
Thank you very much. Two really important concepts, two really important. I would add to the equity quality, Diane, quality of care. So equity and quality of care are extremely important. And then the ultimate responsibility. Peter, any comments?
So on the equity, I think there's probably two separate things here. There's the sort of population health and reducing population health inequalities. That's partly to do with access to services, but a lot of it actually sits outside of health service sphere. You know, it's cross-working with others because we know that population health is determined by 80% of factors outside of healthcare. So things like housing, things like behaviors, things like socioeconomic issues and so on. So there's a big sort of program of work happening there for the Making Life Better initiative. And it is one of the minister's absolute key priorities. And he has a new initiative called Live Better, which is about bringing services into two areas of deprivation, one in Belfast, one in Derry, I think it is, as test areas to try and reduce, try and see what impacts we can have on health inequalities in those particular areas. I suppose then there's access, so equal access to services, I suppose is the other point of this. And as Mark says, to quality services that are safe. And that's very much what I think that this document is about. So it is about, and I say it's about working to how do we best allocate resources across a hospital network to try and I suppose maximize equality of access to care. And I think that's alongside the quality and safe services. So I think there's always a bit of a tension, but that's what it's about. And I know examples of where this is actually happening already in some specialties where people are thinking about how we can be best spread the resource to provide as much access as we can.
And I think it's important to say that, you know, in the world of general surgery, because I take your point, Anne, is about general surgery, that really is now abdominal surgery in the same way as getting a cardiac stent requires an interventional radiology team in either Belfast or Alton and Galvin. General surgery now, very often, it's about using a range of added specialists such as interventional radiology, bleeding rotas and gastroenterology. And unfortunately, throughout the United Kingdom, the general surgeon who could open a chest, open an abdomen, deal with traumas isn't there anymore, which is why in terms of trauma, which is always confused with of emergency abdominal surgery. An abdominal surgeon's the last person you want in the trauma. You want an orthopedic surgeon, you want a neurosurgeon. That's why we have a call and send policy throughout Northern Ireland. Multi-injured patients, no matter which casualty, are call and sent to Belfast, where there is a multidisciplinary, multi-trauma team ready to save your life. And I cannot, on public forums, go into what we had in the past that was regarded as equitable. It wasn't. It wasn't equitable. People were getting a postcode lottery in the delivery of emergency surgery. So thank you. Trauma is not part of emergency general surgery. Helen, I've said it so many times. I'm not answering it anymore. Now, can we go to Camille Horan? Camille.
Thanks, Mark. So for anyone who doesn't know me, I'm postgraduate dean. I look after about 1,800 of our resident doctors, previously known as junior doctors. Very important part of our workforce. I'm mainly here to listen today because I feel we need to know what the service models are going to look like in order to be training up the medical workforce, GPs, consultants, and other doctors. So again, I think a few comments I would make, very focused on what services look like rather than structures, so to speak. We know that a lot of our doctors in training, they want flexibility. And I think it's interesting what we were talking about. We need that workforce to be flexible as well. So we need to train them in that way so that they can move in different sites and do different things. So I think there's going to be a bit of negotiation there across that. We really do need to be patient focused. That's our 100% our goal, and that's where we're starting point. And from my point of view as a training organisation, we're also trying to engage more with the patient voice. But I do think another group of stakeholders are our healthcare workers. And we really need to think about what environments we're putting them into, what support we're giving them, very much in order to attract workforce, but also to retain workforce as well. And I think there's a whole big discussion as to whether we're training medics, other people in the right way to actually provide the services that we're going to need in the future. So really interested in this conversation and how things will look like in Northern Ireland. Think we could be world leaders on the basis of our size, both in training as well as in services. But I'm really interested in how this conversation proceeds. But I think the hospital structures, Mark, are probably only one part of it. And I was Googling who Eddie Ritson was, because I'm really also interested in how technology is going to take us forward as well. And there's all sorts of things we're not touching on, like artificial intelligence, which will be really helpful as well, because that's going to really transform how we may be working. And I think there's other pieces of work, Peter, that you'll be involved in, like the work we're looking at reducing medical locum spend, which I think will open up looking at what our rotas look like, what the composite of our rotas is, how we're using our teams together. So I actually think there's a lot of quite exciting conversations going on at the moment, but mainly I'm here to listen and learn.
And I think that's really helpful, Camille. And I think I would say to everyone, you know, that it's not just about patients traveling. It can't be just about the public traveling, the professions, the clinicians. We have to be part of that travel process too and continue to be part of that. I'm keen to maybe get a lived experience or one of our patient client council representatives, maybe from the northwest of this wee province. Have we anyone that wants to make any comments? Again, I've tried to go down through the list here, and I'm just wondering, I know Aidan, you're on as a senior medic in the Northern Trust. Is there anyone wants to make any comments just from the Northwest? Obviously, we're in a public consultation at the present time around the Northern Trust. And I think Camille's right, you know, the distribution of workforce, sometimes it's difficult to predict that when there is change afoot. And what does that mean? We've already had discussions around bringing our trainees into the elective care centres from all over Northern Ireland to really get hands-on experience and really cement that training opportunity. Anybody want to make a wee comment from up around the Northwest or even Southern? Aidan, do you want to say a few words?
Yeah, no, just no, thanks. I've been really interested in hearing everyone's perspective so far. No, Camille, agree wholeheartedly, I think, and I think certainly what we've noticed in the Northern Trust, we did have quite a high locum spend, specifically within the acute team. but we've really gone to a lot of effort to reduce that and have gone on a big recruitment drive of kind of trust, sort of locally employed specialty doctors, who are a real cornerstone of the service now. And I know NIMDA's now taking on more of a sort of role with regards to SAS doctors as well, and sort of their training. And I think it is the most rapidly growing sort of group of doctors now within the NHS. And I think when we are looking at how we're going to support all of these different areas, I think having the kind of these locally employed doctors to be able to work there and support those services and provide that kind of continuity, consistency that rotating doctors don't always give, I think that is really important. So I think more needs to be done for the SAS doctors, better representation, more kind of educational opportunities. If they want to then Caesar eventually in the future, become consultants, more support that way. So I think there's definitely an evolving role there. I suppose the only other thing from a Northern Trust point of view, as I mentioned before, was the kind of regional differences, and we are looking at that in terms of obviously us having kind of the oldest demographic in the region, but then that's not reflected necessarily in terms of the service that we can offer, acute care at home, frailty hubs, all those kind of things, even the kind of proportion of care of the elderly physicians, stroke physicians that we have, the trainees or the registrars who can come. So I think that's part of a larger work of looking at the needs of an area and tailoring the workforce, the services that you offer to what that area's biggest needs are. So I think from our point of view, that's something that's a big priority for us.
And thank you, Aidan. And Monica mentioned it as well, some of the really sterling work going on in the Southwest region. We've heard in previous meetings about our southern sector and, acute care at home that's going on. And again, also, as you say, work afoot. So there's an awful lot of exciting projects which are trying to bring us shift left. We have talked about that before. They are trying to move the tanker away from these facades called hospitals. Just before I give the final words to Peter, I just want to make sure there is no last burning questions. Just to make everyone aware, I think it's appropriate for me to say at this stage that there was an announcement made today about the new interim permanent secretary, and that's Mr. Mike Farah, who's no stranger to these shores. I personally would like to pay tribute to Peter May for his service over the last 3 years as permanent secretary. Peter's with us until April. And I definitely wish him very well after a very distinguished civil service career. And I would imagine every one of us on this call look forward to working very, very constructively with Mike Farah as he comes in for this interim role. And I'm just going to go to Peter for any closing comments.
Yes, and before Peter jumps in, Mark, just to say, we'll be on it and trying to see if Mike will come and do a Grasping the Nettle seminar for us as soon as we can get him in and he's settled. So.
Thank you. Peter.
Thanks, Mark. Thanks, Heather. Thanks for hosting this and chairing it, Mark. I think it's been really helpful, useful discussion this afternoon, sorry. And thanks everyone for taking the time out. I think these are really helpful to get everybody together and get a debate on these issues. And I hopefully some of you will, on the back of this, put in a consultation response as well to the consultation. Would be very, very helpful to us, particularly if there's specific points that are maybe relevant to the consultation document itself. Really keen to hear them. So thank you.
And thank you very much, Peter. And I think just in closing, we all are patients. We all will be patients. And we all have loved ones who are patients. And each and every one of us, no matter what our walk in life is, want the very best for our families and therefore the very best for our patients. And whilst we've enjoyed a robust discussion, I think it is really important that we continue this conversation and we continue to work and allow those who have the expertise in one area to drive in that area, those who have the expertise in another area to drive in that area. And I think let's all work constructively together for the better good of our society, because we've been trying this for a number of years and a number of reviews and a number of reports. It's time that we made progress collectively as a society. But just on behalf of NICON, to thank each and every one of you for your contributions. I think it's been a very robust discussion. I hope we have gathered in a representative of the group today, and just to wish you all a very pleasant rest of the day. Next webinar is on my favorite topic, finance. So you'll all be able to come and listen to Bridget Worth talk about finance and the budget for next year. So if you want a really cheery session, join us for the webinar coming up next. Thank you all very much. Have a lovely day.